Hi, my name is Joel Asunto. I'm a second-year resident at Adventist Health Tulare. Today I'm going to present a rare case of neuromyelitis optica spectrum disorder. Prior to that, I would like to acknowledge my colleagues, Dr. Omole and Dr. Nameni, and also the faculty involved, Dr. Royter, Dr. Salmons, Dr. Patri, and our respected PD, Dr. Khan. Going over with the introduction, neuromyelitis optica spectrum disorder. It is also known as Divik disease or neuromyelitis optica. It is more common in female than male, about 10 times, at ages 32 to 41 years old, primarily African American and Afro-Caribbean, but it can happen to other races as well. You need to come up with or figure out the core clinical diagnosis plus positive antibody of AQP4 IgG. And also you need to exclude multiple sclerosis and myelin oligodendrocyte glycoprotein antibody disease. You can do imaging, however, it could be normal or sometimes it's non-specific. And if it is present there, the area prostrema, perithrid, ventricle, fourth ventricle, splenium, diffuse corpus callosum, pencil thin ependymal, or cloud enhancement that you can see. You can do CSF also, and you should be able to see lymphocytic, but sometimes it can present as neutrophilic or eosinophilic, which can tip you off to a different diagnosis. You might think it's a bacterial meningitis or fungal meningitis. Typically, it relapses and usually without second progression, attack-related accumulation of the disability. As you can see here in the picture, it could damage the myelin sheath and subsequently damage the neuron, the entire neuron, actually. So this started with this patient who came in to the ED. He's a 37-year-old male with past medical history of congenital intellectual disability. He presented with a headache, left lower extremity weakness, and numbness, and it started about 3 days prior to coming to the ED. And it has progressed to loss of balance and bladder incontinence, and he didn't have any medical records except one he had brain surgery or skull surgery back in 2016. Had surgery in Stanford Hospital. So we requested medical records during the time. And while doing that, we did ask more questions, and he said he smoked like 20 pack a year. Cigarette smoking. He doesn't really drink, but just social drinking. He tried some drugs, but has not been using in a while. He's currently living with his girlfriend and has normal functional status, working as a custodian. And he rides his bike every day, so he's pretty much ambulatory person. On physical exam, he was tachycardic, tachypneic. He was AO times 4, satting room air, but he's not really following commands. But that could be because of the congenital intellectual disability. He was wiggling his feet, but was unable to stand up and walk. He had impressive, significant left lower extremity weakness. The motor function is 1/5. Sensor is diminished. He has hyperreflexia, undergarment covered with urine and feces. We check his labs. He had some leukocytosis, hyponatremia. Creatinine is also elevated, so he must have EKI, and the CRP was really high, and there's like inflammation going on. So we did MRI. It was showing suspected ventriculitis and transependymal edema. MRI of the T-spine has a normal signal from mid and upper thoracic spinal cord. And as you can see here, these are the MRI of this patient, and with the details here also that you can read. MRI of the C-spine is also showing this hyperossency here. hyper intense. I mean, they did CSF, and they found out that the antibody for AQP4 was positive. They also did a biopsy of the brain, and it was showing demyelinating disease in right temporal lobe, which is during the time we received the brain biopsy from 2016, and they're actually consistent with one another. So just for discussion purposes, NMOSD is a rare neuro disease. It involves, during this process, a lot of his specialty were involved in this. This is the findings in the MRI. He has some transepidermal edema, an abnormal signal from the mid and thoracic spinal cord. CSF was positive, biopsy was showing demyelinating. It's really consistent with NMOSD. And it was diagnosed by Adventist Health, Hanford, prior to getting the report from Stanford Hospital. Patient was initially treated for meningitis, but then it was de-escalated, and he was started on this medication listed here: methylprednisolone, flex, eculizumab, and completed it. And the patient improved, but then he was waiting for transfer to Stanford Hospital. They just want to make sure we're not missing anything. Upon review of Stanford Hospital's medical records, it was actually similar to what we have. It's in a different part of the brain, but yeah, he was also AQP4 antibody positive during the time. He was actually treated and was discharged, but then he was non-compliant and was lost to follow-up. These are different imaging here that you can review. This is the most common one for multiple sclerosis, but these ones are for the AQP4 NMOSD. This one is pretty common also for NMOSD. Here in the MOGAD, and there could be some optic neuritis. So they have different MRI. You can compare them and see how they differ from one another. NMOSD is a rare autoimmune disease found in less than 5,000 individuals. Understanding the core clinical symptoms: AQP4 IgG, antibody positive, and MRI combined leads to optimized treatment and better dispositions. You must be able to do the differential diagnosis and rule out these other two to be able to diagnose AQP4 NMOSD. All right, so NMOSD is typically can typically relapse without secondary progression. This is the acute treatment: IV glucocorticoids and plasma exchange. Maintenance treatment includes eculizumab, inebilizumab, and satralizumab. And they also use the off-label azathioprine, mycophenolate, rituximab, tocilizumab. Thank you so much for listening. That ends my presentation.